I'm Dr. Omid, interventional cardiologist working in Oman. In this video, I want to talk to you about prostatic artery embolization. Prostatic artery embolization is purposeful blockage of arteries supplying prostate by particles like microsphere and glues. And this blockage in turn causes prostate to shrink. It's not always all about physical shrinkage of prostate. Sometimes distraction of nerve fibers, adrenergic nerve fibers, reduces the spasm in muscle fibers of prostate, and it softens the prostate and reducing the pressure on urethra. Historically, prostatic artery embolization came up as a side effect of treating hemorrhage of prostatic cancer. It was noticed that in addition to stopping bleeding, the procedure resolved the urinary symptoms which was present in the patient before. So this is the concept. By starving the prostate gland, by stopping the blood supplies as much as we can reduce the size, we can shrink the prostate, and we can soften it. Then we have less pressure on urethra, less pushing up on bladder, and less urinary symptoms. We have three modalities of treatment available for treatment of benign prostatic hyperplasia. First, medical treatment, drug therapy. Second, urological surgical procedure. And third, prostatic artery embolization. Medical treatment is an effective modality for many patients. Alpha blockers and 5 reductase inhibitors are the mainstay of treatment. But the problem is that some patients do not respond and some develop side effects that prevent effective treatment. Now we have surgical urologic procedures. They are more effective and more rapid acting than prostatic artery embolization and medical treatment. Procedures like TARP, Urolift, and Resume. It is because they involve removing prostatic tissue directly and opening the urethra directly. So it is more effective and more rapid acting than prostatic artery embolization and medical treatment. But prostatic artery embolization involves starving the prostatic gland. It is like killing someone by knife or gun versus putting him in a jail and starving him with intent to kill. It is obvious that the first method is more effective and more predictable. So what are the benefits of prostatic artery embolization that we emphasize on? The main advantage of prostatic artery embolization is the ease for patient. It's much like an angiographic procedure. No need for general anesthesia, just mild sedation. The only pain is mild pain related to injection of anesthetics, local anesthetics, same-day discharge, rapid ambulation, going to work the next day. No need for any precaution, even taking medication, taking previous medication. No need for any specific limitation, especially if it is done through radial approach. No need to have a catheter, a fully catheter in place, except in special situations, because nothing done through urethra, not even touching prostate. And prostatic artery embolization lacks 2 important complications of surgical urologic procedures. First, incontinence, and second, decreased libido, sexual desire. Patients with large and very large prostates benefits most from embolization. Embolization is easier in these patient subsets and they are less suitable candidates for classic and modern surgical urological procedure. Also, embolization can still be performed in patients with a smaller prostate, like 30 to 50 gram, but there are many novel urological procedures out there that can be performed, like TURP, Rezum, aquablation, and urolift. Also, there are patients with comorbidities which prevent them undergoing surgery. These are also candidates for prostatic artery embolization. The effectiveness of prostatic artery embolization means that the symptoms of patient relieves, and if a patient is on another modality of treatment, he can put that away. For example, if the patient is taking medication, he can stop medication and he has no any symptoms either. If we keep this definition of effectiveness in mind, we should say that prostatic artery embolization is effective in more than 80 to 90% of cases. Also, prostatic artery embolization, in terms of restoring urine flow in urethra, is not as effective as surgical urologic procedures that involve removing tissue from prostate, and also the effects are much later than that. It should be noted that, as I told you previously, this procedure, prostatic artery embolization, is very, very patient-friendly. That's to say, patients are very easy with this procedure. And it lacks two important complications of surgical urologic procedures: incontinence and sexual dysfunction. This really depends on doctor's opinion. Personally, I prefer my patient to be visited by a urologist to be sure that the patient's symptoms, like urgency, is due to benign prostatic hyperplasia and not to other less common conditions like neurogenic bladder and urethral stricture and other conditions along this line, which cause symptoms like BPH, but actually prostatic artery embolization won't do nothing for these conditions. I also like to have a CT angio of pelvic arteries before doing this procedure, to have an impression of any abnormalities in pelvic arteries like stenosis, like tortuosity, and also to have an assessment of the volume of prostate. Actually, there is no action to be done, no specific action to be done before angiography and prostatic artery embolization. Just a simple lab test, CBC, and coagulation profile of patient suffice. Even